Hello, my name is Regina Cortez, and this is my neuro project on music therapy. A lot of people wonder how specifically can music be used to benefit the lives of our future patients. When utilized strategically, music has the power to heal, physically, mentally, and emotionally. Specifically regarding PT, music therapy may be utilized in conjunction with mobility to increase sensory, motor, and cognitive deficits, directly affecting the brain's ability to send signals to the upper extremity, lower extremity, and during gait. Music has cognitive implications as well. Although most of us are not certified music therapists, PTs can utilize aspects of music into mobility to make treatments more meaningful. In a journal article from 2015 regarding neurologic music therapy, it goes into depth about how music can influence and change activity in sensory motor functions in the frontal, parietal, temporal, and occipital lobes. It gives background on how instrumental music training may lead to adaptations of various cortical and subcortical brain structures and functional networks. It also talks about how music is a powerful driver of beneficial brain plasticity, with a specific motivational and emotional role of music experience, having a wide range of physiological effects. It was utilized in stroke patients, resulting in an increase in neuronal connectivity between sensory, motor, and auditory regions, which was demonstrated by EEG coherence measures. There are various types of ways music therapy may be implemented into physical therapy treatment. These include rhythmic auditory stimulation, listening to music, and incorporating it into balance, coordination, and strength. It is a unique approach to traditional treatment that may be memorable as well. The frontal lobe is involved in the guiding of attention in planning and motor preparation, in integrating auditory and motor information, and in specific human skills such as imitation and empathy. Multisensory integration regions in the parietal and temporal occipital areas integrate different sensory inputs from the auditory, visual, and somatosensory system into a combined sensory impression. It is this multisensory brain representation which constitutes the typical music experience. The cerebellum is another important part of the brain that plays a critical role in the musical experience. It is important for motor coordination, but also plays an important role in various cognitive tasks, especially when they include demands on timing. Typically, the cerebellum is activated in rhythm processing or tapping in synchrony with an external pacemaker, such as a metronome. Finally, the emotional network is crucial for the emotional perception of music, and therefore for an individual's motivation to listen to or engage in any musical activity. 2 weeks ago, I was very blessed to have a delightful patient who I will go into more detail about. I learned a lot from my session with her and thought she would be a perfect candidate for music therapy to be implemented into her interventions. Regarding this patient's health condition, she primarily had a traumatic brain injury with a GCS score of 3 at the scene, L3 to 5 disc fractures, a spinal cord injury, and left upper extremity and cervical fractures. Regarding her activities, she was min assist for bed mobility and sit to stand, and with sitting balance, she was able to sit statically with supervision and dynamically with contact guard. For standing balance, she was able to stand statically with min assist and dynamically with min assist with 2 people. For ambulation, she was mid-assist with 2 people with handheld assist for 75 feet with verbal cues for ambulation, and we did not attempt the stairs. Given her injury, she is currently unable to provide the most optimal care for her son independently or participate in work or in the community. She has a supportive family, and she's 25 years old and speaks Spanish and English. There were a few things that we had to be cautious about during the treatment, and they were that she had bilateral splints, she had a cervical collar on, an abdominal binding, and she had her cast taken off, but now she was weight bearing as tolerated in her left arm and still weak. During our session with her, we were able to address many of her impairments and had a chance to see improvements in her balance and gait from what was documented from the day before. We were also able to facilitate with weight shift at her pelvis and provide external cues to optimize her movement. Given her previous brain injury, she was still responsive and cooperative, but had some delayed reactions and was sometimes repetitive with her speech. With her gait, I could utilize something called rhythmic auditory stimulation as an external pacemaker. With gait, she had decreased step length, a narrow base of support, and trouble coordinating the timing of her steps. What is going to be shown is an example of that type of treatment. To address standing balance, cognition, and coordination, music can be linked with hip abduction and cognitive tasks in changing the leg moving with a change in music. Approximation may be applied to the pelvis if needed for extra stability. Shown is an example of a variation of that task. To address her sitting balance, I could teach her to hit a drum in various directions. I can initially begin this task by keeping the target within her base of support and applying approximation for additional stability and educating a family member on holding the drum instead, then progressing with varying surfaces and longer distances to reach for. To address her left upper extremity weakness after being immobilized from her previous fractures, I can incorporate range of motion and active movement with a functional task like shaking maracas to increase the use of the affected upper extremity. Although music therapy may be beneficial, there are certain barriers in incorporating this treatment. It may be difficult to use in more crowded settings like a PT gym. Outside equipment may be needed to provide optimal treatment. Many facilities may be foreign to the thought of music therapy and may need additional education before executing. Regarding carryover, it is crucial to try to turn the external cueing of music into internal cueing when the music is not available. Also, as for any other treatment, there is no guarantee that the patient will cooperate or they may be shy. It is important to weigh out the pros and cons of this treatment to ensure optimal patient-centered care. Although there have been various studies done, as shown in this systematic review, with positive results with improvements in gait parameters, timing, and communication, more high-quality randomized control trials are needed before recommendations can be made for clinical practice. This requires standardized means of comparison with less bias. Ideally, in the future, there will be further research on this topic to make it a norm to be incorporated into neurorehabilitation.